ask Professor Zareba to give his lecture.
Thank you very much. You can hear me and you can see slides? Yes, Gary?
Yes. Yes, I can. We can all see and hear, yeah.
Yes. So thank you again. It's my pleasure to participate in this webinar, focus on electrocardiology. I will be speaking about diagnostic and prognostic significance of ECG changes in Lund syndrome. Lund syndrome is a genetic arrhythmia disorder that occurs in about 1 to 2 to 3,000 people. It's characterized by QT prolongation, usually above 440 milliseconds. There is predisposition to torsade de pointes VT, recurrent syncope, and sudden death. This particular disease manifests by QT prolongation, but as we know from the early stage of genetic era, when we knew only loci, not just a specific gene, Dr. Mike Vincent presented this figure in this first paper on genotype-phenotype association, showing significant overlap between healthy people and Lund QT people, especially in the range of 420 to 480 milliseconds. We have to remember that this is quite significant proportion of this patient. By the way, in our cohort is about 40% of patients who are gene positive. They may have below 470. Patients may present with some very minor changes, and some of those QT duration or prolongation might not be that easily appreciated. This is why people should really carefully measure such ECGs and measure QT and determine whether QT corrected, in this case with Bazet formula, is eventually borderline or diagnostic. You may see that this was borderline prolonged, but you already may appreciate that some of those T waves, especially V4, V5, are not very normal, and you could see that also in limb leads they are pretty flat. Here's another example of ECG from a patient with LQT2 type disease, where you see quite flat T waves in limb leads, and also some inversion of T waves in V1, V2, V3, V4, and flat V5, V6, as you may notice. So in this case, we always have to pay attention not only to QT, but we always encourage physicians to look at morphology. The morphology of ECG in Lund QT patients has been recognized many years ago. Emanuela Locati was co-author of this paper from 1991, which was done by our group here, Dr. Arthur Moss and colleagues. And you may see that using some computerized approach to superimpose precordial leads, 5 in fact precordial or 6 precordial leads, one could appreciate that in normal case you may see quite homogeneous repolarization across the leads, whereas in case of Lund QT patients there is quite big kind of heterogeneity of morphology. Not speaking about QT dispersion now, but more like dispersion or heterogeneity of shapes of T waves. And colleagues at that time, Yahu Ben-Horin, Mario Murray, and others, they developed some metrics which allow to look at those differences like early duration, late duration of repolarization, whether measured to T maximum or T offset or some area under the curve, which showed quite significant differences in this heterogeneity between these two ECGs. They look at that time at 300 normal subjects and 37 Lund QT patients for whom they had digital ECG recording using Marquette program. Few years later, we work on genotype-phenotype associations, and we found that there are differences in morphology of T-wave. As you see on the first panel, we have LQT3 with quite remote T-wave and a little bit peak T-wave in this particular exam. LQT2, as I mentioned earlier, especially limb leads show a low amplitude T-wave, and in LQT1, which is chromosome 11, this is some widening of T-wave, which we could see both in limb leads and precordial leads. So those LQT1 type of ECGs are more like normal ECG, but there is some widening of T-wave. What is interesting, because there is predisposition of finding women with long QT, especially after puberty, and they represent vast majority of patients identified with QTc above 440. But we look at that time with Emanuela Locati being first author at the group of probants, and proband is first identified member of the family, 330 women and 144 males. And here we have their family members, respectively 600 and about 400. And what you can appreciate that there is no significant difference between men and women in terms of duration in this pre-specified high-risk group like proband. The average was 517 and here 515, and for family members obviously is shorter, 480 and 480. Here all of them were, we call them affected above 440, and we appreciate the fact that despite the fact that we have more women in those cohorts, as it's shown on the right, women dominate especially after puberty. There is no significant difference in QT duration between men and women in such long QT cohorts. We know that when you look at adulthood among healthy subjects, QTc in women is somewhat longer by about 8 milliseconds, but on average. But in case of pre-specified group of patients like that, you don't see these differences. Dr. Jean-Philippe Couderc, working with us here at University of Rochester, he is a professor of bioengineering on top of working with us in cardiology. So he developed a number of methods and number of programs to quantify morphological changes. And you have example here of LQT2 changes. He put together a paper published in 2006 and look at eventually various slopes and area also under the curve. And this particular matrix is truly helpful in differentiating patients with versus without long QT. And these are ROC curves. The lower one is for just QTc only. And when he added QTc, slope of the left ascending arm of T wave and RR in the model, therefore he got much better prediction of proper identification of carriers with borderline QTc in comparison to non-carriers. So this kind of approaches could be exercised automatically, but manually they could be also accomplished. The other way of looking at repolarization duration and to some extent dynamics was proposed also by Jean-Philippe and colleagues by looking at so-called QT clock, as it is presented here. And QT clock works like that we have a 24-hour clock from 0 or 24 hour, 3 a.m., 6 a.m., 12 noon, and you can see the healthy subject, and you have superimposed LQT1 in upper portion, separately male and female, and here you have LQT2 superimposed in comparison to healthy subject. And you may already notice some differences between LQT1 and LQT2. that LQT2 during night hours, they seem to be a little bit more prolonged than during day hours. This is not exactly the same shape as in case of LQT1. So this concept could be applied also, obviously, to in terms of looking at some prolongation and circadian changes of this repolarization. We also analyzed heart rate dependency in this patient population, looking at LQT1, LQT2, and some healthy subjects. And there is difference between these two types and healthy subjects. And the next graph is just looking at T-wave measurements and heart rate dependency. And you may see that LQT1 seem to adapt pretty well between 600 millisecond to 1200 millisecond RR, whereas in LQT2, you don't have this response. So T-wave amplitude in this case, or T-wave magnitude, is really relatively flat here and does not respond that well to changes in the heart rate. T-peak, T-end seem to be not that responsive, and it should not even be considered for any correction, as some papers try to do from time to time. We also look at repolarization dynamics. Dr. Juha Perkiomaki spent some time with us several years ago, and we look at some cohort of long QT patients versus non-carriers and healthy subjects, and we found that repolarization complexity was significantly different. We look also at the time and heart rate variability, but obviously repolarization duration, any measure over here of variability were higher, but repolarization complexity was another approach we exercised. So not only looking at morphology of amplitude of T-wave, but looking at these additional changes may help. And this is from another cohort which was participating in the study focus on emotion in long QT patients, where we collected Holters in some LQT1 and LQT2 patients. As you see, QT standard deviation or standard deviation of QT peak, so-called QTVN by Dr. Berger approach of QT lability, as he calls it. This is QT variability with numerator without adjustment for heart rate variability. QT-VI is adjusted for heart rate variability. Both of them significantly more abnormal in LQT2. When we look at QTRR slope from the same Holters, also slope is steeper in LQT2 than LQT1. And when we try to look what kind of individual QT correction we can develop based on LQT1 cohort versus LQT2, you see that slope, that coefficient is higher, close to 0.5, like in Bazet, and here it's more like Friederichia correction, 0.3. So those differences exist, and one could explore them further. Everybody nowadays is very interested in machine learning and artificial intelligence, and earlier this year, Dr. Ackerman from Mayo Clinic group presented some interesting data. They used some prior library of ECGs of patients from Mayo Clinic, substantial numbers, as you see, 1.6 million 12 lead ECGs digital. They use deep neural network, and they derive some algorithm to diagnose QT prolongation. And subsequently, they try to validate this on about 680 patients with genetic disease, 50% of them with long QT, and they use this ALIF-Core CardioMobile 6-lead version. And as they published some of these results, this is comparison this Blunt-Altman plot for prediction of QTc Bazet. And obviously there are a number of outliers here, and the area is minus plus 25 millisecond here. So still, I would say it's not fully satisfactory. When they apply the algorithms to the 600 genetic inherited arrhythmia patients, they got pretty good area under the curve, or very good along 0.92, 0.91. And this algorithm was well identifying some abnormalities. In the paper, they use cutoff of 500 millisecond, which is pretty high cutoff, for which they had excellent results. So I think that machine learning could be utilized. There is still room probably for improvement. Morphology of T-wave, I'm sure, had influence on some of the spread of those points on the left. Switching for a moment to predictive value of QTC, is the paper we published many years ago, focusing on family members only to avoid being biased by probants who usually have very long QT. And as you see, there is very nice proportional jump from less than 0.45 all the way to above 0.5 with hazard ratio of about 4.8 in such people. So there is obviously association between QTC and cardiac events. And this is some other paper a few years later. But what I wanted to pay attention to is that QTC has this significant association per 10 millisecond increase. It's about 1.07, meaning it's 7 exponential in this case. So you can partially compute a linear association here. But we have, of course, done a number of projects where we look at specific cutoffs. And not only us, many people explore QTC above 500. Here is some proposition from Silvia Priori, looking at various risk factors, including genotype, but QTC, as you see here, above 500 or equal, is there and the top, indicating high-risk people, which we need to remember. There is another paper from our group where we look at adults between 18 and 40, and this is how the scale is going between age 18 to 40, and you have risk of aborted cardiac arrest or death, not syncope. This was harder endpoint, and you see there is really significant jump if you go from to 500, especially above 550 in terms of risk, and this risk is like 3.3 in QTC 500 to 550, and at least 550 or more is about 6. So really very high hazard ratio for this patient population. And importantly, Dr. Goldenberg from our group did some analysis of people after age 40. So this time scale starts at age 40 and goes for 35 years up to age 70. And you have QTC above 470 over here. It's also higher risk than those below. So also in older adults with with long QT, you may expect more events. Morphology of T-wave, as I mentioned earlier, is important. We developed some time ago this kind of schema for different morphologies, and especially those flat or those bifid notch or broad slow were in our interest. And some time ago, we look at the abnormalities of this T-wave and risk of cardiac events, especially in long QT2 patients. And we look at cohort below QTC below 500 or equal and above 500. And as you see over here, presence of abnormal T-waves in those with shorter than 500 QTC was associated with increased risk of events. Whereas among people who already had very prolonged QTC, the addition of normal or abnormal T-wave information didn't really change prediction. So below 500, we are gaining. Above 500, we are not gaining that much because we already know that risk is very high. And Dr. Platonov, whom we will hear in a moment, he put together a very nice analysis looking at risk stratification in patients with normal QTC interval. And you may see that, interestingly, on left we have males, on right we have females, that in males there is no that much difference between normal, abnormal, and people with who are non-carriers. Whereas in case of females, there is really a significant difference. So this brings interesting points that some of these abnormalities might be observed more frequently. Finishing, As I mentioned earlier, those QTCs are always important in prediction and trying to identify people who might benefit from ICD therapy. We developed some score to be applied in patients who didn't have aborted cardiac arrest, so those with other indication. As you know, aborted cardiac arrest is clear indication, whereas the remaining patients always pose a question, and the score includes QTC below 500, 500 to 549, and above 550, and it definitely dominates, as you see on the left, QTC below versus above, and the risk of appropriate ICD shock is substantially higher. At like 6 years is 38 versus 14%. And lastly, just 3 weeks ago, we published this paper to focus on effectiveness of ICD therapy in patients with long QT. And what I wanted to stress, we found very significant reduction by ICD 86% for aborted cardiac arrest, syncope while on beta blocker 73% reduction, and syncope of beta blocker, but with QTC above or equal 500, also 58% reduction. So this last group is kind of more disputable group when ICD could be considered. So let me finish by saying that careful analysis of repolarization duration and morphology, both in static and dynamic condition, provides really vast opportunity to enhance process of diagnosing long QT patients. We like very much looking at T-wave morphology, so identifying abnormal T-waves markedly improve sensitivity of diagnosis, especially in LQT2 patients who have very characteristic changes. And an additional point that evaluating dynamic features of repolarization, both duration and morphology, may help us further. We didn't have time, but there is definitely even difference in response to beta blockers in some of those patients, depending on morphology of T-wave. And lastly, we should remember that QTC above 500 is really predictive for life-threatening cardiac events in long QT patients. Thank you very much. I will stop sharing. Happy to take some questions.
Thank you, Wojciech. It was a very, very interesting presentation.
Nice to hear you, Emanuela.
Yeah, you're used now to be far away.
So maybe I'll start off with a quick question, Professor Zareba. So I'm not sure what you think about the dynamics of repolarization. I'm just wondering if you've had any experience in looking at electrical restitution as a risk stratifying tool for LQTS patients, and whether they help to stratify the adverse outcomes.
We did not directly. You know, classical restitution requires pretty much GP testing to be done, let's say, more traditional way, and we did not have access to such data. But we look at some halters and trying to understand response versus heart rate changes and sudden changes in heart rate caused by, for example, change in body position or some other factors. One could eventually explore it. And as you probably know, Dr. Viskin from Israel and some other colleagues, they try to explore this so-called QT stretching method by analyzing QT in the position of supine position versus standing position. And this kind of approach may help identify people who overreact. And another way to look at it is simply evaluating QT over 24-hour halter. And my experience with that is that abnormal QT will be if you see QT above 500, even in people who have standard QT about 450 or 440, but during night and other periods, if it's above 500 in your halter, this is something which is indicative of abnormal repolarization and needs to be tested.
Adrian, do you have a question?
First of all, hi everybody. Excellent talk, Wojciech. But this is for Gary. The chat function seems not to be working. Is it only me or is it for everybody? Because I wanted to type something and it says that it's not shared.
Strange. It doesn't seem to be disabled, but let me just have a quick look. Yeah. Please continue. I'll try and do some troubleshooting.
Okay. Thank you. Great presentation, Wojciech.
Thank you.
Wojciech, so would you recommend the general use of Holter for, in a sense, detect the burden of QT prolongation? Could we see things in this way? Also for like borderline patients, not rely anymore only on the measurement of QT at the baseline, but really rely much more on Holter burden.
I fully agree with what you just said, that every case which is especially borderline below 470 would benefit from looking at Holter changes, especially in duration, but also in morphology. You may identify some significant changes at different heart rates. So I strongly recommend Holter in borderline cases. Whether benefit of Holter in cases who are clearly prolonged is really worth doing it. One could argue, as I mentioned, in patient above 500, this Holter will not help you that much. You may catch some PVCs or even non-sustained VT, but I don't think diagnostically that helps. But in borderline people, yes.
Yeah, I think that maybe we should consider to make like a consensus paper as ISHNE, etc. on this concept of Holter burden.
I see one question from Adrian about cardia and QT measurements. I'm aware of one or maybe two papers looking at QT measurements. As I mentioned, the one from Mike Ackerman, which also was another paper just by hand measurements. We are currently planning to start a study with cardia where we will look at QT measurements too, not in long QT patient, in some other patient population. But I believe the quality of measure of ECG is pretty good, and therefore I don't expect that will be different. This is already half an hour. I don't want to over-dominate this entire session. My suggestion is that if there are some questions, please type them, and maybe later on we will continue this discussion, but I suggest that we move to Piotr's presentation.
Yeah.
Wojciech, this is Takanori. Brief questions. Could you tell us a clinical use of exercise ECG testing in long QT syndrome? Yes.
It's a very good question, and yes, there is room for improvement based on exercise testing. As you know, colleagues from Canada publish several papers. Your group published good papers on the topic too, and we believe that you may eventually help diagnosing borderline patients, and especially recovery period in number of them will be particularly useful when QT doesn't come back to normal values in minutes 3-5 after exercise.
Thank you. Yeah.
Okay, should I start sharing?
Yes, please. That'd be great.
Yeah. Hello, everybody. Great to be here today, and I see many familiar faces and names on the chat list. So I'm going to talk about the diagnostic and prognostic significance ECG in the context of arrhythmogenic right ventricular cardiomyopathy. And first, a few words about what it is. And in its classical phenotype, ARVC is a desmosomal disease, meaning that it is related to the changes in the desmosomal proteins, or rather genes coding desmosomal proteins, of which plakophilin 2 is the most common finding in patients with ARVC. However, recently, 2 years ago now, came the HRS consensus statement that put ARVC in a broader perspective of arrhythmogenic cardiomyopathy, which is a group of cardiac diseases where the ventricular dysfunction is associated with very significant arrhythmia, ventricular arrhythmia as a part of the phenotype. And depending on the degree of involvement of right or left ventricle, different forms of the disease have been described. And in the context of my talk, which is about ECG in ARVC, I have to say that we should remember that as yet, it's right ventricular cardiomyopathy for which we have a task force criteria, including the ECG criteria. We do not yet have any validated criteria for other forms of the disease. So what I'm going to talk about is the ECG in the context of right ventricular cardiomyopathy. And if you read the task force criteria, you appreciate how heavy is the weight of ECG in the diagnostics. It both includes the major criterion as epsilon wave, which is defined as a reproducible low amplitude signals between the end of QRS and the onset of the T wave in right precordial leads, and terminal activation duration, which is measured as a distance between the nadir of the S wave in lead V1 to the end of QRS complex in the same lead. And if it exceeds 55 milliseconds, then the criterion is considered minor depolarization criterion. Similarly, repolarization abnormalities have been appreciated as a part of the phenotype in ARVC since many years, and also depending on its extension of the T wave inversion, they are separated in minor and major. Major meaning that you have a T wave inversion stretching from V1 through V3 and beyond in some patients. In some cases, you may actually reach diagnostic threshold for ARVC by only looking at the ECG. And in this case, for example, if we see a patient who comes with ventricular tachycardia with left bundle branch morphology and electrical axis pointing upward, already that gives you one major point for the very specific for ARVC ventricular tachycardia coming from the right ventricle with the superior axis. If you, in addition to that, observe T-wave inversion in precordial leads reaching V3, then you get one major point. And in these patients, you can also see that even the minor depolarization criteria is fulfilled. And I'm showing this just to emphasize how heavy is the weight of ECG patterns in the diagnostics of ARVC and how cautious we should be when we interpret that when we are approaching the diagnosis of patients with ARVC or suspected ARVC. Because it's been shown repeatedly, though in the small groups here, we have 38 patients in this study and not many patients in this study, I don't have a number on the slide yet. But you see that if you take the ECG at baseline and then a few years later, you may discover that some patients actually lose diagnostic criteria that were present at baseline. Like in this case, it would be T-wave inversion, V1, V3 or beyond, and 7 patients did not have it at follow-up. And similarly, in this study, you see that some patients would sort of downgrade their phenotypical expressions on ECG from major repolarization criterion to minor, or from major to nothing at follow-up. And that's emphasize importance of ECG, and sort of we should keep in mind that we need to pay attention to how stable are the ECG changes that we are using for diagnosing patients with ARVC. Epsilon wave is another issue that has been discussed recently. When you read the definition in the task force criteria document from 2010, it seems very straightforward. However, because it's a major criterion, that means in reality that depending on how we interpret irregularity in the terminal portion of the QRS complex or beyond that, you don't need much more to put a label of definite ARVC on a patient. even without needing to have any imaging characteristics. So what we did a few years ago is that a few experts representing different ARVC registry worldwide were asked to label ECG patterns in leads V1 through V3 by saying whether it represents epsilon wave or not. Simple binary question. And at the end of the story, we came up to the few cases where it was consensus between 7 reviewers in terms of epsilon wave pattern being epsilon. In 8 additional was consensus that it was not epsilon. And then there was quite many cases where there was no consensus. Then we compared how prevalent were epsilon waves in different registry, and we observed variability of prevalence among different cohorts reported worldwide, likely reflecting differences in our approach when we diagnose patients of having epsilon wave or not on the ECG in lead V1. Fortunately, if we exclude epsilon wave from diagnostic score of these patients we worked with, only 1 of 106 would actually lose the diagnostic status of definite IRVC, suggesting that epsilon wave, whatever it is a late manifestation of the disease, and at the time point in life when a patient would fulfill that, would develop epsilon wave, many other criteria are expected to be present to be sufficient for diagnosis. So our conclusion from that work was that an isolated epsilon wave should not be considered as a major criteria in cases when the only other finding is the family history of ARVC. And this is especially relevant for family members who undergo clinical screening, and we might be too sensitive for irregularities on ECG, risking putting the definite RVC diagnosis with all the consequences it may have. In risk stratification, and I will be talking about primarily on primary prevention, because if patient survives cardiac arrest and they have indications for ICD because of that, we don't care much about ECG, honestly. The patient would fulfill indication for secondary prevention ICD anyway. But if we look at the primary prevention cohorts, purely primary prevention, then there are not that many reported. There is a data from Johns Hopkins in Baltimore. There are data published from the North American multidisciplinary study of ARVC. And 3 years ago, we published our experience from Nordic ARVC registry. And if we look through different characteristics of patients in those different studies and see which of them do have prognostic value in univariate or multivariate analysis or not, then first of all, the groups were very small. Even though we claim to have the largest, it was way below 100. But T-wave inversion was the finding that was reported in the North American registry, and it was significant in our registry. So repolarization abnormalities were considered to be important associated with the outcome, even though there was a very variable findings across different cohorts. So there was an initiative undertaken by the international consortium with Julia and Catherine Turigny taking initiative in putting together the risk calculator for ARVC, and cohort behind this risk calculator is about 800 patients altogether from different countries in Europe, Canada, and United States, who were assessed with regard to the risk of any sustained ventricular arrhythmias or life-threatening ventricular arrhythmias. And this diagram on the left represents those different factors associated with either sustained VA, or on the left side, those who end up in the risk calculator for life-threatening ventricular arrhythmias with a short cycle length. And you see here that in both calculators that are otherwise available at arvcrisk.com, where you can try and see how much your patients would fulfill and what is the risk of developing arrhythmias. The number of leads showing T-wave inversion, both anteriorly in the precordial leads and interiorly, was strong and significant independent risk factors factor for developing the associated with the outcome. And I strongly recommend you to check these papers if you haven't yet seen that. Some words of caution, and one of this is that I think there is a growing understanding that task force criteria as they are formulated in 2010, that's been now 12 years ago, and they are not sensitive enough, as we believe, to detect early stages of the disease. When we looked in the Nordic data, we observed that quite a few patients who did not have ECG criteria fulfilled still had echo abnormalities on imaging abnormalities by echocardiography, and suggesting that ECG, the way they are formulated in task force document, are not sensitive enough. There are other approaches that can be tested in detecting the substrate. In the study that's done using vectorcardiographic measures, in this case recalculated using the transform from 12-lead ECG, we've observed that patients with ARVC diagnosis who did not have any ECG-related diagnostic criteria had been in the same range of vectorcardiographic measures as patients with overt manifesting ECG phenotype, and strikingly different from those without ARVC control subjects. So that it's a problem with 12-lead ECG in the way the criteria are formulated, because the ECG abnormalities are there, and we just need to find a way to pick them up and assess properly. We do need more data, and now when we have large clinical data sets with a lot of ECGs collected from patients, for whatever reason they contact a doctor, we may look back in time and see what happened before they got diagnosis. What was the ECG substrate then? Our first attempt to use that approach was published in EuroPace this year, where we looked at atrial substrate, and we were able to see what happens with ECG markers prior to diagnosis, which is a time zero here, and how they develop after that. And for some variables like P-wave duration, we did not observe much of a difference. For some of them, like P-wave terminal force, the prevalence of that, we observed that it was the late manifestation of the disease, similarly to the P-wave area that we observed here. 2017, we presented our first experience with a small data set of 78 patients only at Heart Rhythm Society in the US, where we had 1,600 ECGs looked like what happened with, for example, T-wave area in V1 before the diagnosis. And we documented years before the diagnosis is set, we see how the T-wave becomes smaller, flatter, with T-wave area becoming reduced, suggesting that there is a concealed phase of the disease that we're not yet capable of detecting using the criteria we have. So a few thoughts in conclusion is that primarily what I was wanting to show is that ECG is a very powerful diagnostic tool with heavy weight in the task force criteria as they are stated now. But instability of ARVC markers over time is likely to be underappreciated, and we need to remember that when we use ECG for diagnosis. There is a spectrum of depolarization abnormalities. We still need some quantification measures. Epsilon wave is a problem, and eyeballing is not enough, apparently. Digital ECGs give us a possibility for automated analysis, and there are new markers emerging beyond 12-lead ECG and simple analysis of QRST complex as we're used to. And we should use those new technologies and new opportunities to learn more about early phases of the disease and its development. And with this, I wanted to conclude. I will be happy to take questions. Thank you.
Thank you, Pyotr, for this wonderful presentation, really rich of ideas and very important points. So now it's open for discussion. Do you have any question? Actually,
Okay.
okay. Sure.
Okay, so this is Takanori. Could you tell us, current status of rate potential by SAECG in this stratification in ARVC? That is, I think, one of the topics, I guess.
Yeah, the late potentials have been shown to be, they currently considered minor criterion, as we all know that. There was an attempt by a Dutch group to put it to assess the value of that for diagnosis, and using the same criteria that is used in the task force, like either of the three criteria fulfilled, they did not show additional diagnostic value beyond other characteristics of the disease. In our study, in the abstract we presented last year in the Heart Rhythm Society, we showed that, and we're putting together the manuscript right now, that the number of, if it matters whether it's 1, 2, or all three criteria fulfilled, it showed strong association with the diagnostic certainty. So I don't think we are yet in the position to sort of completely reject the late potentials, because it seems to be related not to either of the three, but the number of the criteria is associated with the phenotype.
Okay, thank you. Yeah.
Nina, do you want to make a question?
Yeah, Pyotr, I'm just wondering, you say that one has to be careful when evaluating the epsilon waves. What about if you do a genotyping and then you get a result that patient actually is genotype positive? Does it sort of does it have an impact on your evaluation then? Is the epsilon wave more? Does it mean more then?
This is exactly the problem, because if you put if you consider the irregularity of the terminal portion of QRS complex in somebody who is mutation carrier, then you're labeling definite RVC regardless, even though there is no other imaging abnormalities or repolarization abnormalities. So and we raise the word of caution for that specific situation that you're bringing up, Nina. So we would expect something else to be present, not only epsilon wave on ECG, to call the irregularity as epsilon wave.
Okay, thank you.
Do we have other questions from the audience? Pyotr, you surely know that together with Peter, we are developing this Chine KG approach.
Yes, I know.
I think this is an excellent model.
I think this is an interesting tool to see the propagation of the ventricular activation and see whether it's associated with the outcome. I would be happy to try that, and I will.
Yeah, and we will be very, very, I would say, more than curious to see whether this has a regional impact and is localized to certain areas, as it might be, in fact. So that would be very, very interesting.
Sure.
There are 3 questions in the chat.
Actually, I don't know how to visualize the chat. It doesn't show to me. So maybe Gary, can you verify this?
I see that Adrian asking about atrial arrhythmogenic left ventricular cardiomyopathy, and as I mentioned, there are no sort of official criteria as for ARVC. Generally, left ventricular involvement is suspected when we have T-wave inversions that are localized on the left precordial leads rather than right precordial leads. But I think we're still in the process of linking the ECG phenotype of ALVC with the imaging characteristics.
Yeah. And then Professor Zareba also had a question. What about QRS fragmentation in standard ECG? Is it predictive?
Yeah, I think QRS. I think the problems with QRS fragmentation is that it's been defined very differently depending on what study you read, and there are studies showing that QRS fragmentation has been associated with the outcome with arrhythmias, And that would certainly make sense because it is a characteristic of the fibrotic substrate in the right ventricle. But I think we need criteria for just as epsilon wave was an issue in terms of different inter-observer variability. The similar study is needed for QRS fragmentation. How small the notch should be so that everybody would consider that as a fragmentation. But I think I should leave the floor to Alex, otherwise time is running up.
Yeah.
Yeah, so may we invite Professor Christensen to give his lecture now.
Okay, thanks a lot. I'm Alex Christensen from Copenhagen. I'm filling in for Henning Bundgaard, who literally lost his voice, but hopefully I'll be able to provide you a bit of insight into this novel phenotype that we are very interested in. And hopefully you can see my screen here. So the topic of my talk today would be Familial ST-depression Syndrome, which we believe is a novel clinical entity. And it's inherited, as the name implies. And I'm going to present first some of the clinical background for it, and then some molecular genetic background as well. So how it all started? Well, actually, it's something that we heard about back in the 90s when we first evaluated this patient. And to be honest, it wasn't me or my colleagues, but some older, now retired colleagues who had this patient referred for evaluation due to unspecific chest pain. And he had an ECG similar to this, and he was actually told to come back the next day because the ECG machine had to be out of order. But obviously the ECG pattern was exactly the same, and he had various kinds of investigations done. He had echoes, actually 2 coronary angios spread over time, and they didn't conclude that there was any underlying structural or coronary heart disease to actually explain these widespread ST depressions. So he was actually just dismissed from further clinical follow-up, and nothing was really done. It wasn't until about 15 years later, when his brother was evaluated, who had an ECG that looked like the one that I'm showing you now, which does look like a bit of left ventricular hypertrophy, but also have ST depression in multiple leads, especially in the lateral leads and in the inferior leads. The next patient we evaluated was his niece, who also had these ST depression of concave appearance, in particular in the inferior and the lateral leads. So this gave us the idea that this ECG phenotype had to be inherited in some way, and it's important to underline that there was no underlying structural or coronary heart disease in any of these individuals that could explain the phenotype. So when we did over time an evaluation of this family, there was actually 8 affected members with the ECG phenotype. And some of the younger generations were at least still asymptomatic, but there was a variety of phenotypes in some of the other family members. Atrial fibrillation was seen, and in some of the older males, they also had some degree of left ventricular impairment. Our proband, who's shown here on the left with the P and the arrow, actually also had aborted sudden cardiac death at the age of around 55. And was resuscitated and an ICD implanted. So we did various kinds of investigations, including genetic investigations, and it didn't really fit into any phenotype that we know of. So it led us to conclude that this was a novel phenotype. While we were investigating this family, we actually learned of 2 other Danish families and a British family and a Dutch family as well, with similar ECG phenotypes and various kinds of predominantly arrhythmias as well. So all in all, this led us to the impression this could be an unrecognized clinical phenotype that hadn't been described before. So our initial findings were that it was unexplained ST depressions in multiple leads, and we could find old ECGs dating several decades back and see that the ECG never normalized. Very contrary to the previous presentation, where we can see in long QT that the phenotype can be very variable and actually change within the same day. This is not the case in familial ST-depression syndrome. Here it is stable, but does get worse when you exercise. So that's a consistent finding that if you stress test the patients, they do get a accentuated ECG phenotype. When we evaluated the families, it generally showed a dominant way of inheritance. And even though we don't have the specific genetic information, the penetrance seemed quite high, as about 50% of the investigated family members also had the ECG phenotype. Another important observation was that the ECG phenotype seemed to be tolerated for decades, or at least in some individuals we could see that from their teenage years and follow them up to the 40 and 50 years of age before they develop any symptoms. The next slide will also show some data on the phenotypic expression, but in our initial findings was that atrial fibrillation, ventricular arrhythmias, and reduced ejection fraction were observed in some patients. We later on looked for more families and had the hypothesis that this was an under-recognized clinical entity. And the data I'm going to present here is based on 14 Danish families, and all of them had at least 2 affected individuals with the ECG phenotype. They were apparently not related, any of these families. In total, we investigated 40 patients. With one exception, there was no underlying explanatory heart disease. There was one individual who had an acute myocardial infarction, and we could actually see his pre-myocardial infarction ECG. He already had ST depressions. They accentuated during his myocardial infarction, actually went back to baseline after revascularization, but the ECG never normalized. All families showed autosomal dominant inheritance with apparently high penetrance. The clinical events we observed in these 40 patients were atrial fibrillation in 10, some degree of ventricular arrhythmias, mostly sustained VT or sudden cardiac death in 5, and other SVTs in 2. And there was one individual with Wolff-Parkinson-White and one with ectopic atrial tachycardia. Some degree of reduced left ventricular ejection fraction was observed in 10 patients. And when we went back and looked at the first available investigations, we could generally see that the ECG phenotype was present years to decades before reduced ejection fraction. There was a male preponderance for arrhythmias and LV dysfunction. Here I've put in Kaplan-Meier plots, and they are separated by gender, and we can see the freedom from atrial fibrillation. That's the upper left panel. That atrial fibrillation is more common in men. The same goes for reduced systolic function, which is panel C at the bottom left. And at the bottom, at the top right panel, we have the freedom from any arrhythmia, which also shows a male preponderance for any arrhythmia endpoint. So what about ECG features? I mentioned that they were mostly in the lateral and the inferior leads. There were no episodes of normalization, and I've put in a few examples here. And they look, to some extent, very stable and very similar, with especially in V4, V5, and LED 2, that they have these the most pronounced ST depressions. We also had a few kids available in the cohort, and what we observed there was that the ECG phenotype seemed to develop around puberty. Here on the right side of the screen, I've put in an ECG from a 6-year-old and the same patient now age 14. And what we could see is he has developed just discrete ST depressions in inferior and lateral leads, which were not present at the age of 6. On the far right of the screen here, we can see that at the age of 15 in another individual, he also has ST depressions visible. So this led us to the conclusion, obviously we need a bigger data set, but that it seems to develop around puberty. And when we did serial ECG analysis, understood in the way that we took the first available and the latest available ECG, and we analyzed these data, we can see that that the ECG phenotype seemed to be stable and / slowly progressive. there was a mean 5.5 years between the first and the latest ECG. And here I've put in the numeric values of the first compared with the latest ECGs in these individuals. So stable to slowly progressive ECG phenotype was the conclusion here. So what about the ventricular arrhythmias? Obviously, that's like a clinical hallmark of this syndrome, and it's of major importance for clinical handling of these patients. Do we have any data there? Yes, we have a bit of data here. And here is a sinus rhythm ECG of a patient with pronounced ST depressions. And this same individual developed ventricular tachycardia. And what really characterized this was it was fast and polymorphic. And we also studied the onset of this VT. And what we showed here is that in these 3 different individuals, that the ECG actually seemed to be stable before arrhythmia onset, meaning there was no long short sequence, there was no ST segment dynamics prior to arrhythmia initiation, and the PVCs that initiated the arrhythmia seemed to be relatively short coupled with coupling intervals of 300 milliseconds to 360 milliseconds. So obviously we need to know more about the arrhythmia mechanism here, but clearly this is of major clinical importance, how best to treat these patients, whether beta block is effective. We do have some preliminary data, but I haven't put these on the slide, but at least from our preliminary data, it doesn't seem that, for instance, beta blockers solves the problem. It's also important to emphasize that we didn't find long QT in any of these patients because it does look to some extent like TDP, maybe not the onset, but the arrhythmia by itself. But we had no cases of a prolonged QT in this cohort. What about the myocardial histology? Yeah, for the research setting, we had 3 patients who, under an approved protocol, had myocardial biopsies obtained. And these patients had their biopsy obtained at various ages, so there could be age-related changes, and also there are different stages in their disease. The first one patient here, that's the program from Family A, and he actually had features like consistent with dilated cardiomyopathy with loss of cardiomyocyte, hypophatic infiltrations, not ARVC, but just the pathologist described it mostly just consistent with dilated cardiomyopathy. In contrast, patient B21 actually just had small infiltrates of fatty tissue, which was not clearly abnormal. And the last patient, which was quite young, actually had normal myocardium. So this just probably mostly represent different stages of the disease, and there were no pathognomonic myocardial findings in these 3 patients. How to diagnose this condition? Back in 2018, when we published the first report on this, we proposed this table with diagnostic criteria, and they were based on that you have to have at least 1 millimeters of ST depression in 7 leads, and the ECG never had to be to normalize, and it had to be inherited. After we analyzed these 14 families, we've just submitted a manuscript where we actually proposed to do the criteria a bit more lenient, because in our experience, the ECG phenotype is not as pronounced in all the patients, especially in the relatives. They can have relatively discrete ST depressions. I think that's what we've learned from other inherited arrhythmia syndromes as well, that we notice the most pronounced cases first, and we later learned that it is a spectrum. We have had several cases referred due to suspected familial ST-depression syndrome as well, but what we actually there are few of the cases that we evaluated where we actually concluded that it was not the case, primarily that we couldn't prove that it was inherited. So it's an important part of the diagnostic criteria that the ECG pattern has to be inherited, and there has to be no episodes of normalization of the ECG. So that was a lot about the clinical background. What about the genetics? So obviously, it's an inherited disease, so it could cast some light on the underlying molecular biology and maybe be of relevance for other inherited cardiac diseases as well. So we worked on this for quite some time. We started out with Sanger-based gene panels, didn't find anything. Did MPLA for larger deletions or insertions, didn't find anything. Genome-wide hybridization arrays for deletions, insertions, etc. Didn't find anything. Did whole exome sequencing actually twice, including copy number variation analysis. Didn't find anything. Did linked analysis using a SNP array, and we actually did find a single locus with a lot score of 2.8. And the last thing we've performed is whole genome sequencing, where we started off in the index family. And we actually started out looking at protein altering variants in the whole genome sequencing, because exome data can have various kinds of issues with coverage and the areas that are not covered well by the exome capture kits. So what we looked in the VGS data was actually on the coding variants first, didn't find anything, tried more lenient settings that the variants didn't have to be that rare, and nothing really came up that was very convincing. But what we did notice is there was actually a group of not very rare variants that seemed to cluster together, meaning that we found the same semi-rare variants in several families. These variants weren't rare enough to actually be a good cause of the disease, but they were probably more a marker that this region was shared. So that led us to investigate actually by putting all the whole genome sequencing data on top of each other to see if there was any part of the genome that was actually shared by all families. And what we discovered there was a haplotype block of 0.53 megabases that was actually shared. So that's a strong argument for that all these 14 families actually share this same variant. And when we did segregation analysis within these families, this haploblock actually segregated with disease as well. Looking at the variants within the haploblock, we found 3 non-coding variants that was of interest. We took the most rarest of these variants and actually did some functional analysis. It's not located within a gene or very close to a gene, so it has to be some kind of enhancer or silencer or some kind of gene regulatory variant. And what we did as the next observation here was that we amplified this area in 3 different fragment lengths, and that's what's shown here in the gray blocks on the left. That's the area of interest in 3 different fragment lengths, and we cloned it into C2, C12 cells. And what we found there was that the mutant allele actually had increased activity, suggesting that the presence of the mutant actually increases activity of this locus. And when we did some in silico analysis, we did see that it actually seemed to suggest that it was a crenation of a MEF2 binding site, suggesting that there was a novel transcription factor binding site exactly where this variant was located. Obviously, we still need to know more. Through which gene does it exert this effect, etc., etc., etc. And we have a lot of more work going on here, but this is our preliminary data so far. So in conclusion, we believe this is a novel inherited cardiac entity. The ECG phenotype is stable to mildly progressive. The ECG phenotype seems to develop around puberty. Atrial fibrillation and some degree of left ventricular dysfunction is common. The syndrome is associated with polymorphic VT and with relatively short coupling intervals. And all of the investigated families shared the same genetic etiology. So what are we going to do from here on? Well, what's the prevalence of the ECG phenotype? What's the prevalence of the genotype? How do we risk stratify it? Can we prophylactically give some kind of treatment, beta blockers, calcium antagonists, or something like that? What's the mechanism behind the arrhythmia and the LV dysfunction? Or more general question, what's the molecular disease mechanism? And obviously for the clinician, what's the optimal clinical handling? So these are some of the aspects we're looking into. Obviously, I didn't do all this by myself. We have a whole group and a lot more people than the people listed here are involved. So these are just some of our main collaborators. Well, thank you a lot. That was a lot of information about this syndrome. I'll be happy to take any questions or comments that you may have. Thank you.
Thank you, Alex. So now we are ready for questions.